Thank you, everyone. Welcome to the Newborn Toolkit webinar. Today's topic is on kangaroo mother care with quality, duration, nutrition, and data that matter to mark World KMC Day. Welcome, and thank you for joining us for another insightful and informative webinar. Please introduce yourself in the chat. Next slide, please. So the Newborn Toolkit is a multi-country, multilingual learning platform for high-quality small-sick newborn care. In 2024, we had over 55,000 users from 170 countries make use of the toolkit, and we encourage you all to share this platform with your network so they get to learn and move faster together. So we have 1,000 tools in 15 languages, technical content in French, and linked communities of practice in French and English. And all of this is to grow closer to the national target to get to improve newborn survival that cannot be met without small sick newborn care. Next slide, please. So today's topic is on kangaroo mother care with quality, and we'll be exploring duration, nutrition, and data that matter. And today is World KMC Day. 15th May is World KMC Day, and this webinar was created to basically promote what people are doing in their different settings to improve the quality of KMC. Please join the Newborn Toolkit to hear about webinars, news, and to share tools and ideas. You can sign up to our Toolkit newsletter using the QR code on your screen now, and follow us on our social medias on Blue Sky, Twitter, LinkedIn, and Facebook. Next slide, please. So just to let you know, our webinars are throughout the year, and on 24th June, we'll have a Born Too Soon themed webinar. And on 22nd July, we'll have a neonatal nurse themed webinar, and we encourage you all to join us so that we can learn faster together. Welcome, please introduce yourself in the chat. Next slide, please. All right, so today's webinar promises to be a very dynamic and informative one, and we've got a brilliant lineup of speakers who will share key insights on KMC, starting with the WHO and ending in Ethiopia. And our host today is Professor Chinyere Ezeaka. She is a professor of pediatrics, College of Medicine, University of Lagos, and Lagos University Teaching Hospital. She is the past national president of the Nigerian Society of Neonatal Medicine, and she is the clinical lead for Nest 360 Nigeria. Thank you so much, Prof. Chinyere, for hosting today's webinar, for gracing us with your presence, and over to you.
Thank you so much, Dr. Mbozo, for that kind introduction. Good day, everyone. And to join Mbozo, you're highly welcome to today's exciting edition, today's webinar of the Newborn Toolkit in commemoration of the International Kangaroo Mother Care Awareness Day, which is actually on May 15th. And the theme for this year is In My Arms, You Thrive. This theme emphasizes the importance of skin-to-skin contact and the positive impact of kangaroo care on the baby's development and well-being. And today's topic of this webinar is so apt, looking at kangaroo mother care with quality. How do we improve on the quality of what we're doing, with emphasis on the duration, on the nutrition, and the data that is key? So today we have lined up very erudite speakers, experts in the field, and we greatly appreciate the opportunity to share these learnings with you all. Thank you so much. So the first speakers will be from the World Health Organization. We have them speaking about overview with evidence on update on kangaroo mother care. And we have two speakers today to give a short introduction on the two. Do you want to share with us WHO's work on kangaroo mother care? Our first speaker will be Dr. Suchita Gupta, a pediatrician with expertise in research and global public health. She serves as the medical officer for newborn health at the WHO headquarters in Geneva. And her portfolio includes leading multi-country research initiatives, contributing to the development of global guidelines, and providing strategic programmatic support to member states. You're welcome, Suchita. You're welcome to this very exciting webinar. And to the second speaker from WHO will be Dr. Sashio Yoshida. She is an epidemiologist working in the Department of Maternal, Newborn, Child and Adolescent and Aging. She has dedicated her research at improving newborn survival, growth and development, and bridging the gaps between what to and how to in improving newborn health outcomes in low and middle income countries. Her research continues to contribute significantly to advancing global strategies for newborn health. I'll pass over now to Dr. Suchita and Dr. Sachio to take over the WHO presentation. You're welcome. Over, please. Thank you.
Thank you, Professor Chandri, for that very generous introduction, and good day, everyone. Now, to tell the story of WHO's work on kangaroo mother care, I'll take you back 10 years to 2015. Next slide, please. At that time, we already knew that KMC could improve the survival of low birth weight babies by 40%, and it was strongly recommended as the standard care for these infants. Yet, there were three major gaps. First, the global coverage of KMC was still under 5%. Second, the evidence only supported KMC that was initiated in health facilities. And third, KMC was only started after the babies were clinically stable, usually between 24 and 72 hours after birth, by which time many preterm deaths had already occurred. So, WHO set out clear research priorities. We needed to understand how can we scale up KMC to reach more babies? Can it be safely started at home? And most importantly, can we begin KMC soon after birth, even before babies are clinically stable, to save more lives? To answer these questions, WHO coordinated a series of research studies. Next slide, please. The first was the KMC scale-up study, an implementation research study conducted in Ethiopia and India, covering a population of approximately 8 million. The study showed that it was possible to increase KMC coverage from under 5% to as high as 53 to 82% across the different facilities. The second was the community-initiated KMC trial in India, which showed that KMC can be safely started at home for low birth weight babies. These were babies who were either born at home or discharged early from health facilities without starting on KMC. And it showed that this could reduce neonatal deaths by almost 30%. And finally, the most important study, the immediate KMC trial, which was conducted across 5 countries in Asia and Africa. It showed that starting KMC within 2 hours of birth, regardless of clinical stability, compared to starting KMC after stabilization, reduced the neonatal deaths by 25%. Next slide, please. Now, this body of evidence informs WHO's updated 2022 recommendations on the care of preterm and low birth weight infants, resulting in 4 major changes to the KMC guidance. These changes were, first, KMC is now recommended for all preterm or low birth weight infants, not just those under 2,000 grams. It can be initiated at home for low birth weight newborns who do not require facility-based care. The minimum recommended duration in contact is at least 8 hours per day, and KMC should begin as early as possible after birth, regardless of clinical stability, unless the baby is unable to breathe spontaneously or is hemodynamically unstable. Next slide, please. Additionally, next slide, please. Additionally, new recommendations were developed on family involvement and support, which are central to delivering effective KMC. Next slide, please. Recognizing the next slide, please. Recognizing the significant potential to improve newborn survival, the WHO Strategic and Technical Advisory Group of Experts, the STAGE, recommended the formation of a global multi-stakeholder KMC working group in 2023. This group was tasked with developing consensus-based approaches to support KMC implementation across countries. The working group developed a global position paper and an implementation strategy on KMC. Next slide, please. These documents, they outline a new vision of newborn care to move from siloed care, where obstetric and neonatal services operate separately, to integrated family-centered care, where the maternal and newborn care providers actively collaborate to keep the mothers and newborns together, irrespective of their clinical condition, provide them with respectful, coordinated care in one space, and make families active partners in care. The strategy offered guidance to countries on how to scale up KMC in ways that can be adapted to their specific health systems, cultures, and communities. Next slide, please. Beyond this, WHO has embedded KMC across all major streams of its newborn health work. As you can see on this slide, KMC is included in the quality standards for the care of small and or sick newborns in health facilities, as well as integrated into the nurturing care framework and early childhood development efforts. It is a core component of the updated Essential Newborn Care course and also the upcoming course on the care for small and sick newborns. It is a core action in the Universal Health Coverage or the UHC Compendium, which is currently being updated, and KMC coverage is one of the 4 core indicators for small and or sick newborn care to be tracked through routine health information systems. Finally, under Every Woman, Every Newborn, Everywhere, or the EVEN initiative, WHO is supporting 55 high-burden countries to include KMC alongside other key recommendations in their country maternal and newborn health acceleration plans. Next slide, please. Now, the final step in the story is translating all this evidence and guidance into action on ground. To support this, WHO is coordinating an implementation research on the scale-up of immediate KMC and is also developing a clinical practice guide to support the frontline providers. With that, I will now hand over to my colleague Sachio, who will share more about this important work. Sachio, over to you.
Thank you, Suchita. Next slide, please. So WHO is coordinating immediate KMC scale-up implementation research in 4 countries: Bangladesh, Ethiopia, India, and Nigeria. The aim is to integrate and embed immediate KMC into countries' efforts to strengthen small sick newborn care. As an integral part of small sick newborn care, the objective is really to develop a scalable model that achieves high coverage of immediate KMC for small and or sick newborns requiring care at level 2 facilities. In this project, Ministry of Health is our co-partners. National government in these 4 countries will be supported for further scale up at subnational or national level. Next slide, please. How do we then develop a scalable model? The chart on your left visualizes that process. Basically, we have 3 steps. Initial phase to set up the infrastructure and start training, followed by government-led co-design workshop to strategize the process. And this process follows by refinement cycle that has a continuous improvement of the model from model 1 to 2, model 2 to model 3. And through this monitoring and evaluation period to assess quality and coverage, and adjustments are done simultaneously. Final model agreement is the last step, and this is to develop a scale-up strategy for broader implementation. Then what are the activities on the ground? At policy level, we need enabling policies and guidelines for zero separation and combined maternal and newborn care in the same place. And then the family must be allowed to enter the newborn care unit. Space in childbirth area for starting KMC and transport of newborn to the care unit is essential. In this project, we have established 10 mother newborn care unit, MNCU, and designs are either adaptation of the existing unit or setting up the new unit. Essential equipment at the facility level is critical. Recliner bed, chairs, KMC binders, and garments are essential for continued skin-to-skin contact. We had continuous IKMC training and small sick newborn care training, particularly increasing the uptake of CPAP and care of the mother in the MSNCU. Robust data collection systems through strengthening of routine care system. We put in place this robust data collection system that really helped to strengthen the existing health routine health system. Then we also strengthen the small sick newborn care in those facilities through continuous mentoring and assessment. Parents, family education and counseling were also put in place. This has been an ongoing program, massive learning through this process, reviews and audits and cross-learning across sites. We're going to touch upon this, but ongoing sharing of findings with the facility leadership, governments, and partners are also in place. Next slides. Yes. So earlier we introduced you the continuous cycle of model improvement. We'd like to share some specific examples. In Ethiopia, data showed that mothers and newborn diets are leading facility early against the medical advice in one of the facilities. So the team there in Ethiopia did a quantitative study through program learning and revealed that food insecurity was the key factor. So having to take the food and buy the food elsewhere and bring it there at the extra cost was the key factor. And we conducted a pause and reflect discussion. The team conducted pause and reflect discussion, and that led to securing free meals for mothers and reducing the problem and improving duration of skin to skin. And this session was done with the Regional Health Bureau. In Bangladesh, the data showed late initiation of skin to skin. And this was because of the lack of coordination between obstetric and pediatric team, and that being identified as a key barrier. So they have put in place a system for a regular perinatal meeting to improve coordination. In India, the health workers were initially very worried and hesitant to start KMC when the baby was on CPAP. So the team conducted the training, followed by on-the-job support, and then hand-holding of health workers by mentors on case-by-case for those each babies, including telephonic supports to build capacity and confidence and competence. And that really improved the process. Next slide. So yeah, earlier I mentioned about sharing early findings when the study is ongoing with the key stakeholders. So this slide showcases some of the specific examples in Ethiopia and in Nigeria with the great efforts with Abi, Fitsum, and then Ebon. The KMC has been integrated into either national health programs or the KMC guideline is being updated. In Hawassa, with the Regional Health Bureau using project facility in Hawassa for on training for further national scale-up, and in Nigeria, thanks to Ebon, the national KMC guideline has been updated to include IKMC. The plans are underway to embed IKMC in additional states, with the project facility in Ocean State serving as a national training hub for excellence. In India, as an exemplary country, IKMC has been successfully integrated into national policy, leading to an expansion of MNCU using the design, training, and material that we developed during this study. Meanwhile, in Bangladesh, the mentorship program continued to grow with the plans to expand it further. Next slide. So this learning has also been incorporated into this clinical practice guide, KMC Clinical Practice Guide. And we are very excited to announce that the updated KMC practice guide will be launched in July. So WHO's last practical guidance on KMC was published in 2003. Since then, there has been significant updates on the recommendation, as Dr. Suchita mentioned earlier, and there has been 4 major updates as described here. But at the same time, there has been no operational guidance at country or health facility level in many settings. Protocols and practice really valid on KMC practice. So there is a need to build the gap between how to implement what works best. There has been a clear need for revised and then hands-on guidance at the facility level, particularly for unstable KMC, which refers to the care of preterm or low birth weight infants who require level 2 care or higher. This new guidance is ready with the internal approval moving forward and the World Health Assembly coming next week. We anticipate the launch will be in July. I will now give the floor back to Dr. Suchita to take us through the historical cycle of WHO's work on KMC. Thank you.
Next slide, please. Thank you, Sachio. So I'll end with this slide, which shows how the story that began in 2015 has come a full circle. From generating evidence to developing guidelines to translating them to real-world action. Now, it is up to all of us to take it forward, creating more success stories, saving more lives, and making high-quality care a reality for every newborn everywhere. Thank you.
Thank you. Thank you very much, Dr. Suchita and Dr. Sachio, for this very, very exciting, informative presentation from the World Health Organization, speaking about the journey of KMC in the past since 20 years, where there was very poor coverage, less than 5%, to only practice in hospitals, and then the fact that it was only instituted for babies who are stable at that time. But through the journey, through the implementation research that were done, WHO has come on with the recommendations and strategies, and then the practice guides based on this implementation research works. Thank you so much for this very, very informative presentation. Thank you. So next, we'll swing over to Dr. Mbozu Sipalo to launch the KMC Quality Action Pathway for countries. Because this, we're looking at learnings, hand-holding for countries who do not have much practice of kangaroo mother care to optimize what they're doing. To introduce Dr. Mbozu Sipalo, she's a Zambian neonatal clinician and a research assistant at the London School of Hygiene and Tropical Medicine. And she's the Newborn Toolkit Knowledge Management co-lead and editorial team co-lead for the Newborn Toolkit. She's actually been involved actively in building a community of practice for the small and sick newborn care for developing context. And she's passionate about fostering collaborations, partnerships, and knowledge sharing in the newborn health space. We hereby welcome Dr. Mbozu for her presentation. Over.
Thank you, Dr. Prof. Chinyere. All right, so hello everyone. Following that really insightful WHO talk on the importance of KMC, we as the Newborn Toolkit are launching what we are calling the Kangaroo Mother Care High Quality Action Pathway. So we all believe in KMC, but how do we make it work well? So we have many people working all over the world to upscale KMC and to have it be implemented in their settings. And this aims to be a platform on the Newborn Toolkit where we simplify the implementation of high-quality KMC through the project management cycle. So we're launching it today, and you see a link in the chat leading you to the action pathway. So the content of the pathway focuses on the domains of high-quality kangaroo mother care with an emphasis on data and action for KMC position, including duration and starting early, which is basically the theme of this webinar today. Nutrition, which is a very important component of KMC, and supportive and developmental care and follow-up. So the pathway collates KMC resources across different health system components with illustrative examples from resources from countries such as Ethiopia, Uganda, the Gambia, and of course, WHO KMC guidelines. So it links quite well with what Dr. Shuchita and Sichaya were talking about. And it is co-designed by all of us, that is clinicians, parents, and researchers. Next slide, please. So this, the previous slide sort of gives you, who is the pathway for? So this is basically the layout of the pathway. Why do we need high quality KMC for preterm, low birth weight and unstable babies? Who is the pathway for? So who is on the action team? What do we mean by high quality KMC? How do we initiate KMC earlier, extend its duration, and effectively measure its implementation? What barriers do we need to overcome? And a few evidence through the resources such as the WHO ones and country examples. Next slide, please. So this basically just gives you a layout of what to expect on the pathway. So the why, what, who, how, overcoming barriers. And we'd just like to show you that it's very concise. And it links to different resources that have been already discussed by the WHO speakers. And we hope that you'll be able to make use of it and share your resources to add on to this platform so that it can be sort of like a one-stop shop for high-quality kangaroo mother care implementation for developing contexts. Next slide, please. All right, so who is the action pathway for? Who is on the action team? So we have parents, caregivers, parents and support groups at the heart of KMC, the healthcare support team, such as nutritionists, lactation experts, physicians, data and QI champions, funders, academics, policymakers, and of course, hospital leadership, such as facility managers. Next slide, please. And what do we mean by high quality KMC? This slide basically just talks about the importance of early, continuous, and prolonged KMC. And of course, we have the recommendation of at least 8 hours daily, and for frequent interruptions to be avoided, breast milk feeding to be optimized, and it's key that we have lactation support for the babies and the mothers, supportive care in hospital for mothers and babies, and early hospital discharge with follow-up and psychosocial support in hospital and after. We have these resources featured on the pathway, and a few of the speakers today will also be touching on the importance of these resources and why they're important for shifting policy to evidence and action. Next slide, please. So a bit about the pathway is that we use the project management cycle to work through the important steps in high quality KMC. So we assess a situation, plan, implement, and use data to make data-driven decisions. Next slide, please. So one of the things that we covered was common barriers to implementation and solutions to address in high quality KMC. So a key question is, how do we start KMC earlier? A few solutions given in the pathway are that we need to start educating in antenatal KMC, and this implementation ladder developed by Dr. Suman Rao from St. John's Medical College Hospital, Bangalore, was quite helpful for us to just understand that it's a continuum of care for KMC, and it starts in antenatal care, but it involves all stakeholders from newborn health workers to the maternal health providers and of course parents, and providing care for the women at all stages is key as well. Next slide, please. So what can each of us do this week? You can share your practical resources for KMC with us to add to the pathway. You can share the action pathway widely with your colleagues and unit leaders. And we can all support caregiver involvement in KMC. And of course, advocate for high quality KMC in all our respective settings. Next slide, please. All right, so the Toolkit aims to be a multi-directional learning platform. So we do encourage you all to share your resources with us and share your tools with us, and contact us at the email on the screen now. And you can also scan the QR code on your screen to access the action pathway and reach out to us to see how we can make it more user-friendly and more action-oriented. Thank you very much.
Thank you so much. Thank you, Dr. Mbozu, for that engaging presentation, looking at the launch of the KMC with a high-quality pathway, with emphasis on the duration nutrition data. Distinguished audience, please, the link is in the chat box, and kindly share widely. And this ended in the implementation ladder on how can we start Kangaroo Mother Care earlier. And this is the crucial gap that we need to close. Thank you. As we move quickly forward, we now move to the data. The data component is crucial. We are implementing KMC, but we're not documenting. And like I said, if it is not counted, if it is not documented and recorded, it is not done. So I have the pleasure to invite Dr. Alex Stevenson at this point. Alex is a neonatologist who works in public and private hospitals in Harare, Zimbabwe. He is the president of the African Neonatal Association and co-PI on the African Neonatal Network, which is a quality improvement collaborative project based on standardized electronic database. So I have the opportunity to call on Dr. Alex to please speak on his key topic today, which is on what can we measure, looking at practical and implementable aspects of this measurement. Over to you, Dr. Alex. You're welcome. Thank you
very much, Prof, and thanks to the Toolkit for giving me this opportunity to talk. Okay, so that's what we're discussing today, about what we can measure. The next slide, please. And this is my disclosure slide that I am a member of an elite group of Kangaroo fanatics, as you will discover as the presentation goes on. Next slide, please. I think before we start talking about what to measure, it's important to start with why, because that then guides us. And there are many different reasons why we measure data, but I think fundamentally we use it as a map, like a GPS position of where we are, where we've been, where we're going. And without that stream of data, ideally in real time, we are not well informed about what is going on. The next slide, please. And so we might know why we want to measure data, but what we actually measure has many factors and parameters. Firstly, the ideal quantitative indicator doesn't exist. You can often get one or two or three of these, but it's difficult to get them all. Like, the ideal indicator should be closely aligned with what you're measuring, go up when what you're measuring is going up and go down when it's going down. And it should be something that you can change through quality improvement. Otherwise, it's just of hypothetical interest. And it should be realistic that your team on the ground can measure this without too much investment of time and energy, and ideally in objective, standardized way. And of course, it should be timely, easy to access, and people should actually use it, because as we all know, I fear much, possibly most data collected is just stored and never used at all. Next slide, please. Okay, so I think we all know that at the moment, of all babies under 2,500 grams or 2,000 grams, our only indicator at present is saying, did that baby ever get KMC? And that's what's happening at the moment within ENAP and within most of our data information systems, and this is a very useful tool, but I think you can appreciate that there's a lot of room for more granular, more useful data. Next slide, please. And so from here, really, it's a work in progress. This is under discussion. These are different aspects of things that we might want to measure. And I think at this point, I would call on people to please join us within the African Neonatal Association is partnering with NEST 360 to form a partnership around KMC. And one of the things that we are specifically looking at is the data around KMC. And we will also be reflecting and trying to come to some consensus about this. And I'd be very interested to see people's suggestions in the chat, and also people can contact me directly or join our working groups. But I mean, it's not rocket science. Besides just asking, are they receiving kangaroo mother care? One could also ask, when did that start? How long are they getting it for? Those are two crucial issues. It has been suggested that we try and measure immediate kangaroo mother care, which should be started within 2 hours. I mean, personally, I think that's too late. Really, it should be within 1 minute. But others suggest within 6 hours. And then how much kangaroo mother care is the baby receiving? And again, that's a sort of moving, do we want to say at least 6 hours, at least 12 hours, at least 18 hours? Because there's evidence suggesting the more the better, and 18 hours plus seems to be giving us the best results. It's important for us to remember we somewhat focus on the fact that we're talking about skin-to-skin care, but there are two other important components to kangaroo mother care. One is exclusive breastfeeding, and one is early discharge and support after discharge. And those are things that we also need to measure. And these become tricky in reality of how you're going to measure them, but we do need to come to some consensus and some standardized way so that we're all doing it in the same way. And we'd also want to be seeing our units aggressively kangarooing even unstable babies, that you could perhaps say, well, is the baby getting CPAP and kangaroo mother care, rather than our sort of old habits of waiting till the baby's pretty much ready to go home and then just giving them a little bit of kangaroo care on their way out. Next slide, please. And so what I was discussing before is around the babies themselves and looking at individual level, patient level data. But it's also important to understand the hospitals and indeed the country. Like, does the hospital have a facility for immediate kangaroo mother care? And that facility, does it have basic norms such as we were hearing from Ethiopia? You know, are the mothers getting fed? Is there space? Do we have collaboration with the obstetric team so that we can look after sick mothers and sick babies at the same time? Do we have enough equipment? Do we have good data systems? Do we even have data points, which is what we're discussing at the moment? Do we have protocols, etc., etc.? I would recommend that people look at the NEST 360 Health Facility Assessment module, which addresses most of these points. Okay, next slide. I'll just go through these two quite quickly because this is some inspirational work from Dr. Tumukunde, who was working with the Mwana trial in Uganda. Firstly, looking at what's out there, how are people trying to measure the duration of kangaroo mother care, and seeing mainly people were either using a patient diary or the health worker record, but also direct observation and devices, which potentially can be a healthcare worker time saver. Next slide. And he then did a study using a gold standard of direct observation and found that, yes, both parent reports and healthcare entries were reliable. The healthcare worker records seemed to be slightly more reliable with a slight underestimation of duration, but it was valid. Last slide. In summary, it's important to measure so that we know what is going on, so that we can allocate resources, so that we can identify bottlenecks. And at the moment, we're using the standardized, did they get any kangaroo mother care in their admission? But going forward, we need to come to a consensus about how we're going to measure quality, particularly when it was started and how long the babies are getting, and also the other two aspects of kangaroo mother care, their nutrition, exclusive breast milk, and their support after going home. Thank you very much. I'll be interested to get people's feedback and opinion. Thanks, Prof.
Well, thank you so much, Dr. Alex, for that very enlightening presentation, looking at data and the measurement and the need for a harmonized framework for the indicators that we're to utilize for KMC measurements. And it's also calling on everyone, all partners, to have this consensus to look at data quality on kangaroo mother care. And this is an ongoing process. So on this point, thank you, Dr. Alex. We want to swing to the other beyond data. One key element of this webinar is to look at nutrition of KMC, which is a key, crucial area of kangaroo mother care. And I have the pleasure to invite Dr. Adriana, who is a Colombian pediatrician. Yeah.
Thank you. Thank you for the opportunity to talk about this important topic on KMC.
Hello? Okay.
Yeah. Well, first, next slide, please. First, I want to remind you the three components of KMC. Please, next slide. The three components of KMC are the kangaroo position, exclusive breastfeeding, if possible, and early home discharge in kangaroo position, and kangaroo nutrition with strict ambulatory follow-up. These three components, you will see in the next slides, how are related with nutrition and growth. Next slide. Where to start and how to start a kangaroo position according to the new evidence, as you have heard. Recommendations are for KMC initiated immediately after birth whenever possible. If not possible, because the baby is critically ill, as soon as the baby is ready for KMC. If the child is born in a community, KMC should be initiated immediately after birth and transported in KMC in kangaroo position to a facility for a first evaluation. The decision to adopt the position must be made based on local experience, local protocols, and always with authorization and close supervision of the health workers' staff. Next slide, please. Next slide. Thank you. Kangaroo position duration is very important. Continuous kangaroo position is promoted in the NICU and is for mother, father, and family members, for example, grandparents. And the goal is to suppress the separation parents and infants. The families need to be in the NICU 24 hours for 7 days. Evidence suggests that the longer kangaroo position is provided, the more weight the baby gains. On the right, you can see a systematic review and meta-analysis from the Kangaroo Foundation. And you can see if kangaroo position is for 6 hours or more, the benefit of weight gain is clear. But on the other hand, if kangaroo position is provided 2 hours or less, this benefit is lost. So the duration of kangaroo position should be dictated by the baby. It should be stopped when the baby is no longer wanting to stay in the kangaroo position and can thermoregulate and is able to thrive without this intervention. Next slide, please. Kangaroo nutrition is according to the infant immaturity. Preterm babies must be placed at the breast for non-nutritive sucking immediately after birth with immediate administration of colostrum. You can see these pictures and you can see how we can extract colostrum with a syringe from the nipple. And in a baby, extremely preterm baby with CPAP, we can put the colostrum into the mouth and also by orogastric tube for trophic stimulation. At this point, stimulation at the breast with the nipple will continue until sucking becomes nutritive. During the phase of stable growth, that is with clinical stability and enteral or oral feeding tolerance, the primary objective is restoring growth to body size appropriate for corrected age and achieving the normalization of body composition. The ideal feeding strategy consists of a direct transition for enteral tube feeding to breastfeeding through direct sucking. What are the ways? Gavage plus sucking stimulation with mother's nipple, oral suction, oral drinking with a cup or drop. Next slide, please. The stable preterm baby should be placed on the mother's breast in the first half hour postpartum to stimulate the mother's milk production and sucking. And if the baby is hospitalized and does not have oral feeding, the mother's, as I said, colostrum should be administered as soon as possible. In infants less than 1,005 grams, enteral feeding should be initiated with exclusive breast milk, but associated with parenteral nutrition. First, started with small doses, but then with a fast advancement. When around 100 milliliters per kilo per day are reached, or 1 week has passed, fortification could be started if the child condition allows it, because of the higher calcium, phosphorus, and protein demands on these babies, on these very overweight babies. Next slide. Non-nutritive sucking is initiated in preparation for direct sucking, as I show you, at the breast and sucking swallowing coordination. When reaching a volume of human milk more than 100 milliliters per kilo per day, with an increasing weight, the tube is removed and the infant is left to suck directly to the mother's breast. If fortification is not possible, there are another ways. The hind milk, and if with the hind milk it is not possible to gain weight, the fortification could be with liquid milk from premature infants. given in a minimum amount with cup or syringe with to avoid interfering with breastfeeding and to improve tolerance. The kangaroo position stimulates breast milk production and should be initiated as soon as possible or for the longest periods tolerated by the infant and mother. The mother can also express her milk while carrying the baby. Evidence, like in the right of the slide, slows an increase in volume because of oxytocin levels. Next slide, please. If adequate growth is not achieved, as I told you, in the ambulatory setting, mothers can use her own hind milk to provide the supplementary calorie intake. Or in the ambulatory setting, after intense lactation, counseling, and not properly growth achieved, supplement with preterm formula in liquid presentation, or fortified breast milk is another option. For donor milk, it could be a second option. A human milk bank with trained personnel is needed. Next slide, please. Also, it's important micronutrient supplementation with vitamins, calcium, and phosphorus, and enteral iron during the first year. Next slide, please. KMC nutrition for achieve the good nutrition, the good quality nutrition, it's important to have a growth monitoring. All preterm overweight newborns should be weighed daily, and length and head circumference should be recorded weekly to ensure that they meet adequate growth and reach the goals for weight, as you see, on length and head circumference. The growth velocity will vary, and it's important to use a growth chart, Fenton growth chart, or after 40 weeks WHO growth chart. The goal is to support optimal neurological and physical development. If it's inadequate weight gain, we can check for breastfeeding support, or if there are increased demands like in BPD or for hypothermia, or look for diseases like anemia or infections. Next slide. This is the diagram of the anthropometric measurements, the transition period with the physiological weight loss, the period of stable growth around 40 weeks, and then the period after 40 weeks, and we can use WHO growth charts. Next slide. The third component is early home discharge in kangaroo position and kangaroo nutrition with strict ambulatory follow-up. For safety, it's important to have eligibility criteria for the child, for the mother, and family support. We have two phases of follow-up in ambulatory setting in kangaroo mother care programs. The first until 40 weeks gestational age with daily weight monitoring, active breastfeeding counseling, as I told you. And the second phase is a high-risk follow-up until 1 year of the corrected age with visual and auditory screening, growth, development, and nutritional guidance. Next slide, please. KMC nutrition is a shared work for the mother and the father and the family. Next slide. We have another experiences, studies on kangaroo nutrition. We have a high altitude, I work in a high altitude city, Bogota, and we have a study with patients with oxygen at home. And it's very important nutrition for oxygen winning. Next slide. The other aspect is nutrition follow-up. This is an article that describes nutrition for 28 years in kangaroo mother care programs. As you can see, parenteral nutrition has improved. Exclusive breastfeeding is high through the time, and extrauterine growth restriction has decreased. Next slide, please. It's important to remind you that KMC nutrition works, but if correctly implemented with the kangaroo position and early home discharge. When effectively implemented, this approach enables preterm or lower weight infants to achieve growth comparable to that of full-term peers by the time they reach term age. Thank you.
Hello? Hello, everyone. Wow. You must agree with me that this has been so engaging and very lucid presentation from the Colombia team. We actually have this wonderful pleasure of having the team from Bogota, Colombia, where kangaroo mother care actually started in 1978. We're speaking about 25 years ago. And then we have the experts, Dr. Natalie Shapak, and Dr. Natalie is actually the founder and the director and head of the research at the Kangaroo Foundation in Bogota. We have this wonderful opportunity to have her at this presentation with Dr. Adriana, who is an associate professor also at the Kangaroo Foundation in Bogota. And they've spoken about nutrition in kangaroo mother care, which is a key pillar of kangaroo mother care. Also looking at growth monitoring, KMC discharge, and KMC support and follow-up. Thank you so much, Bogota team. Please, audience, we have in the chat these wonderful links to these presentations and to some key publications. So as we move forward, as we're rounding up now, we're talking about learnings from other countries. How do we handhold each other so that we practicalize and implement kangaroo mother care in our various abodes to save newborns and reduce neonatal morbidity and mortality? So at this point, we want to learn from Ethiopia. And we have Dr. Fitzen, the Gabriel Belay, to talk about kangaroo learning from Ethiopia on doing KMC for more hours and how to start earlier. To introduce that Dr. Fitzo is a neonatologist and associate professor at the Department of Pediatrics and Child Health at Hawassa University College of Medicine and Health Science. She's also a national clinical lead for 7 Little Lives 360 in Ethiopia. She's a co-principal investigator for the immediate KMC implementation research in Ethiopia, and she has worked on shaping lots of national policies. To congratulate her on being a recipient of the Pediatrician of the Year Award for 2024 by the Ethiopian Pediatric Association. Please we welcome Dr. Fitzen. Over, please. Thank you.
Thank you, Prof. Cinieri, for the kind introduction, and greetings from Ethiopia. And thank you for the Newborn Toolkit team for inviting me to speak on KMC learnings from Ethiopia on 2 important aspects. The first being on starting earlier, and the second being on doing more hours. Next slide, please. So on doing more hours and starting earlier, the learning is from 7 Little Lives 360 supported facilities, as well as IKMC implementation research facilities. And I'll be sharing our learning on behalf of the team. So one of the key elements in the ladder that you have already seen earlier, and the one that you see now, is initiating KMC early, that is at birth. Context-wise, this refers to initiation of skin-to-skin care at labor room or operation theater for those who have delivered via cesarean section. Time frame for early initiation is within 2 hours, and delivery then eventually transporting in KMC position to MNICU. So context-wise, it's important to understand when we say early, it is immediately after delivery, but within a window of 2 hours, which includes initiation and transport in the same skin-to-skin position. Next slide, please. So from practice and also from formative assessment that we have identified key elements for successful initiation of early skin-to-skin care, and I'll be discussing 4 key elements. The first one is clear implementation guideline. As you can see in the picture on the left of the screen, Ethiopia has developed and rolled out for reference the National KMC technical as well as implementation guideline in 2023. Having a technical and also implementation guideline has helped us to standardize the care, increase resource mobilization, facilitate capacity building, and get the buy-in, especially from regional health bureau authorities as well as facility leaders. And the second key element is establishing strong and sick and small newborn care. It's really challenging to do early skin-to-skin care for a preterm or low birth weight baby in the absence of quality sick and small newborn care, like initiating CPAP in the labor and delivery room, maintaining the warm chain and the infection prevention and the like. Hence, strengthening the sick and small newborn care is key element to introduce early skin-to-skin care in the labor and delivery ward. Next slide, please. So the third key element is strong collaboration between maternal and newborn care team. You cannot think of initiating early skin-to-skin care without engaging the maternal team. So for successful initiation, you need to work in close proximity with maternity care team by friendly approach and also collaboration with the obstetricians and also the midwives by avoiding the blame and shame relationship, which is very key for establishing collegiality and also understanding that immediate initiation of KMC is a shared responsibility to be carried out by pediatricians only. So if you have that collaborative platform, it is very easy to clearly set the role one, to also to assign assignments and also mobilize resource for smooth initiation of immediate KMC. The fourth key element for initiation of early skin-to-skin care is empowering the mother and the family. We should always think of the mother and the family whenever we think of KMC as a whole. So again, we focus on this, and usually we tend to find the mother in a MNICU, but it doesn't work if you think of early initiation. You have to get the mother during the NC follow-up. Here, embedding in the counseling, especially the need to bring a companion, birth companion, also surrogates, and discussing the benefits of doing immediate KMC is key to prepare both the mother and the family for smooth early initiation of skin-to-skin care in the labor and delivery room. Next slide, please. The next learning is on to share is on doing more hours on skin-to-skin care. Next slide. So what are the key elements? Again, overall implementation of early initiation as well as continuation of KMC really requires a mindset shift, especially on the value of having the mother with the baby in the unit. A mother's rightful place is with her baby, nowhere else. So mothers should be provided with paid monitoring and treatment in the mother newborn intensive care unit. Respecting and caring for the mother is key for doing more hours of KMC. So you cannot think of prolonged hours of skin-to-skin care, which is key for improved outcome of the baby without the mother. The second one is conviction of the staff, and this is conviction on that KMC is a standard of care for preterm or low birth weight babies. Belief is contagious. If you don't buy it, you can't sell it. So we as clinicians, we need to be able to believe in KMC, then eventually whatever you are convinced with, it's very easy to implement and also to convince others. And this can be achieved through different ways, some of which is training and identifying champions and leaders to normalize KMC wherever it is being provided. Next slide, please. The third one is peer support. Mothers do well when they see other senior mothers or previously admitted mothers doing KMC for longer hours. We use these experienced mothers to teach new moms on different aspects of KMC, one of which is longer hours of skin-to-skin care. This is so encouraging. Instead of us discussing longer hours of KMC, which is very key, it is more prominent when other mothers actually take the lead to convince and also support other moms. So the peer support is crucial. And next slide. So the last one is measuring hours on skin-to-skin care, which is very important. The healthcare team should follow hours on KMC to plan to do more or to improve or to encourage mothers who care doing who are actually doing great. So the only way that we could know if we can only follow the hours on KMC using different tools or checklists. So until we have monitoring technology to do so, we depend on our clinicians or nurses and midwives in the unit to follow hours on KMC. So on the picture that you see, this is one of the care forms that we use in the unit, which actually tracks who is doing the KMC. Is it the mom? Is it the surrogate? And also hours on KMC, how long are we doing? This is very important. So having the tools on board is key, and also making a decision based on the finding is very important. So availing the checklist, maybe it may not be enough. Staff orientation and clear role assignment is very crucial so that it can be monitored and eventually plan can be set during clinical care of the patient, the baby, as well as the mom. So these are the key learnings that we have on initiating KMC early and also doing more hours. Thank you very much. Back to you, Prof. Chinere.
Thank you so much, Dr. Fitzum. This has been so exciting and engaging. Thanks for your very informative presentation on KMC key learnings from Ethiopia on these critical steps, looking at how do you move from policy to implementation with emphasis on family-centered care. You're looking at peer support, and then use of monitoring tools, looking at an overall mindset change. Thank you, Dr. Fitzum. That has been wonderful. So thank you so much, dear audience. This has been quite a very exciting afternoon, looking at Kangaroo Mother Care International KMC Day on quality, looking at the duration, nutrition, and data that matter. So great appreciation to the Toolkit team, and the recordings will be shared on the various platforms. And we also have the opportunity to thank the funders, etc. Over to Mbozu. Thank you so much, everyone. And thanks for your kind attention. Over, please.
Thank you, Prof. Chinere, for hosting us
Thank you.
today. Happy World KMC Day, everyone. And thank you for joining us. Till next time. Bye-bye.
Bye. Bye, everyone. Thank you.